today's session. It will be on our Canvas page, and we use these recordings, one for you guys to go back and review after the session, as well as that for educational purposes and quality improvement. We're really glad that you've joined today's session. If you will take a minute and change your name to where you work, where you're from, your name, anything that you want to share with us, and hub members, if you will put an asterisk in front of your name, that just is allowing all of us to know who a hub member is. If you have any questions, please reach out to them. And as we do breakout sessions, it helps Bailey organize those. ECHO is a community, an interactive community. So please put your comments and thoughts into chat. Reach out to colleagues on the call. And if you are interested, a case narrative is a great way to solidify any of the skills learned. It's also a great way to problem solve and get additional resources for the families that we serve. So if you have a case that you want to present, please reach out to one of us and we'll be thrilled to get you on our schedule. As always, anytime we're talking about families, coworkers, anything that's identifiable, please remember to protect their individual privacy. So if you have any questions, again, reach out to one of our amazing hub members. They'll be able to answer any of those questions for you. If you've never joined an ECHO session before, it has some key components of that. And there is a didactic speaker. We have a case presentation that we then problem solve and get recommendations for in our small breakouts. And then we're also hoping and wanting to build that professional networking and community of practice. So the more often you attend ECHOs, the more often you are to know that you can reach out to Shelby and she'd be able to answer a question for you, or to Pat and she can explain some things that happen in the NICU. And that's where it becomes really important to put your name and contact or your discipline into when you rename your profile. And we store all of our information on our Canvas page. We also do a certificate of attendance. So the survey will be dropped throughout chat in today's session. Take a minute and fill that out. That's how we then email our credit for attendance. We do store everything on our Canvas page. So if you've not got an invite for that or you would like one, please just email earlyecho@usu.edu and we will get you set up on that. Again, case studies are a great way to get information from your colleagues, from other people on the call about difficult cases or even just fun cases that we're working on. We do have our Facebook, Instagram, and LinkedIn page that we share information on, useful tools that we get from participants and speakers. So please follow us. I'm thrilled again to have Ashley Stuart coming in to talk to us about autism in toddlers. This will go for our next 4 months, is where we will be talking about autism. So I am going to stop sharing and turn the time over to Ashley and let her take it away.
Hi all, thanks for having me back to talk about my second area of expertise and passion, which is early evaluation and early symptoms of autism. So get my screen shared up. I'm here today as but one person of part of a larger group of individuals. So on behalf of the entire Aspire team, I am a clinical child psychologist at the University Developmental Assessment Clinic. But the work that I'm going to be presenting today and the presentation I'll be presenting today is something that we have collectively as the Aspire team developed. get my controls going. Just a quick note, which is that we have no, there we go. I'm the one with the technical difficulties, by the way, as you can probably tell at this moment. Hopefully I've got them resolved. Just a quick note that we don't have any commercial financial relationships to report, but our work is funded through the support of Intermountain Foundation at Primary Children's Hospital under the Aspire project. And you'll hear a little bit about Aspire today, but essentially Aspire stands for Autism Services Personalized, Integrated, Research-Informed, and Empowering. And through this project, we conduct a variety of statewide initiatives and research throughout the state of Utah. Today's educational objectives include understanding epidemiology related to autism, although I know one of my colleagues, Dr. Builder, is going to deep dive into that a little bit more for you next time. I'll just introduce it in prevalence and then really anchor that in the importance of early identification and diagnosis of autism. And we'll do a deep dive into some signs of autism that you might see in some of the young children that you work with. So autism is a neurodevelopmental disability, and it's characterized by social differences as well as restricted and repetitive behaviors. And there's really a wide variety in presentation of autism. In fact, Dr. Stephen Shore is known for a pretty famous quote, which is that if you've met one person with autism, you've met one person with autism. Autism is a diagnosis that's considered to be a lifelong diagnosis. And one thing that we do know about autism is that the more early we can identify autism, the earlier those children can have access to intensive interventions, which can effectively improve outcomes. Something else I like to introduce at the beginning of any talk about autism in particular is the concept of neurodiversity. In the world of disability, the voices of self-advocates matter. So I am using words from the Autistic Self-Advocacy Network to educate us all about this concept. Essentially, neurodiversity means that no two brains are exactly the same. Every person has things that they're good at and things that they need help with. And there's really no such thing as a normal brain. The neurodiversity movement, in fact, says that people with brain-based disabilities, such as autism, intellectual disabilities, learning disabilities, or mental health disabilities, should be accepted and included in society, just like neurotypical people, so people without brain-based disabilities. And really, this neurodiversity movement also says that we shouldn't try to cure or get rid of autism. Autistic people should be allowed to exist, and we should work to make sure that everyone gets the accommodations we need to reach our full potential. And I think that this is a really important concept that we really, as individuals who work in the field of developmental disabilities and neurodiverse populations, should really strive to be grounded in. And so I would encourage you all, as you discuss autism in toddlers, as well as you have case conferences and case presentations, that you keep this important fact in mind. The other thing I like to point out is that you'll notice throughout the presentation that I use person-first language. So I try to say child with autism, as well as identity-first language, autistic individual. I came from the learning group of learning to use person-first language, but many self-advocates and their allies prefer identity-first terminology. So in presentations, I tend to use both interchangeably throughout my talks. In terms of prevalence of autism, current developmental monitoring statistics indicate that about 2% of children in the United States have autism, and this translates to a ratio of 1 in approximately 36 children. The increase in prevalence is really reflective of several things, including an improvement in outreach, screening, as well as destigmatization of the autism diagnosis among different communities, including minority communities. In terms of an autism diagnosis, we know that boys are still 4 times more likely than girls to be identified. We also know that approximately a third of individuals with autism have a co-occurring intellectual disability. And that co-occurring intellectual disability often is characteristic of individuals who may require more ongoing services, and who have caregivers who are going to benefit from increased support as well. And compared with previous estimates that we've had in the past, the prevalence is starting to increase, but some of the racial and ethnic disparities in terms of percentage of children identified and age of diagnosis continue to persist, though they are slowly improving, which means that there's still work to be done with these groups. In spite of the severity and the behavioral characteristics of many children with autism and the efforts to improve the identification, we still see the average age of diagnosis in the United States being somewhere closer to 4 years of age. But we know that there are many risks processes that are happening much earlier than that. And so part of this discrepancy between the age of diagnosis and the symptoms of autism being present is likely due in part to some of the differences in patterns of onset in children with symptoms, and essentially waiting for them to meet the threshold for diagnosis at different points. What we know in terms of early diagnosis is that we can reliably diagnose autism in children as young as 2 years of age, and that stability of that diagnosis in children over 2 years of age is really stable. However, more recent research has also demonstrated stability in children who are diagnosed as young as 14 months of age. In that study where the children at 14 months of age showed pretty strong diagnostic stability, the stability was not present when they looked at children between 12 and 13 months of age. In fact, it increased almost 3 times as much when the child reached that 14-month threshold. So it does seem to be like at this point in time, like that 14-month time point is kind of the lower end of the diagnostic stability threshold. So why do we want to recognize early signs and symptoms of autism? Well, as I mentioned earlier, our ultimate goal is really improving the lives and functioning of all individuals with autism. And so the earlier we recognize these signs and symptoms of autism, the quicker we can get these children on the path to the evaluation, which can then lead them to that early treatment and early intensive services, which show us those improved outcomes long term. So knowing that early identification is really important, the question then becomes, what do we know about early signs of autism and how we can identify children with characteristics of autism? A bunch of really great research, much of it kind of prospectively following children at higher likelihood for having autism, show that first, there's a lot of heterogeneity in the presentation of autism, and that from a clinical standpoint of what we would see, there's no consistent, reliable, and specific behavioral markers for autism before the first birthday. But when we look at more group level things, signs that are more indicative of autism seem to fall into the differences in social communication and repetitive behaviors that emerge during that second year of life. And we're going to go through these signs specifically here in a moment. When it comes to looking at early autism diagnosis and early autism markers, one of the biggest challenges we have as clinicians is differential diagnosis. And that's because many of the signs and symptoms that we'll describe and go over today are things that we do see in children with other developmental delays. So a lot of times what we're looking at is variety and frequency in many of these skills that I'll point out for you today. And that seems to be a big piece of what differentiates children with autism from children with other general developmental delays, including isolated speech and language delays or global developmental delays. When it boils down to it, when we look at social communication and social interaction, it does seem like profiles of social communication may be a big piece to understanding this differential diagnosis and comparing children with other developmental delays to children with autism. Secondary to that, in terms of restricted and repetitive behaviors, there are some specific profiles of play that we see in younger children who end up with a diagnosis of autism that also differentiate them from their peers with other developmental disabilities. Delays in some areas during the second year of life, like I mentioned, might be more associated with developmental delay rather than specifically associated with autism. And some of it has to do with the trajectories that we see unfolding in really young children with autism. When we look at some of the research that's been presented on developmental trajectories in autism, what we see is that during that first year of life, oftentimes children with autism look pretty similar to children who are typically developing, but that those differences in their developmental trajectories start to emerge in that second year of life. So that's why we're really emphasizing this period between 12 and 24 months as being a good time to start to identify this gradual unfolding of symptoms that may result in a later autism diagnosis. The other thing that I'll emphasize today as we go through the developmental signs and symptoms that you might see in toddlerhood with autism is that it's also really helpful if we're always grounding ourselves in where the child's overall developmental level is. For many of the symptoms that we're looking for in the toddler years of autism, if we have a child who has a really significant developmental delay, say, for example, they're functioning more at a 3 or 4 month developmental level, but they're 2 years of age. One thing that we might be looking for is a nice variety of gestures, including a point. But what we know about pointing is that that's something that typically emerges closer to the first year of life, the first year of age. So a child who's developmentally at a 3 to 4 month developmental level wouldn't necessarily be expected to reach that milestone of pointing yet. So as you're assessing or looking for signs and symptoms, just remember to always kind of ground yourself in where the child's overall developmental level is. The other thing that makes this assessment of autism in toddlers fairly tricky is that anyone who's a parent to a young child knows that all children develop at different rates, and there's lots of variability in how children develop, especially when it comes to communication skills. So a lot of what early identification research has been focused on is how to figure out when these divergence in developmental trajectories are significant and when they seem to classify children who are at risk for more persistent developmental delays. So let's start with really young kids. So while I mentioned several times that there are no really reliable specific behavioral markers prior to 12 months of age, some children who are later diagnosed with autism may have symptoms including a lack of a social smile, very limited or reduced eye contact, They may not respond to their name consistently, especially if we're looking at a child between 9 and 10 months developmental level, when we would expect this to be more concrete. Lack of social babbling. So even before children are able to communicate expressively, like using words, they still engage in some of the foundational communication skills. I know I have many speech language pathologists on this call as well. So you know how important these early social communication skills are for the development of verbal language. So when we have a child who isn't babbling or taking turns in babbling with caregivers, that can be an early sign. We also see fixations on unusual objects. So getting caught up in parts of objects versus playing with the whole toy. It is, of course, important to understand the limitations of these observations at a young age, and know that there will be children who end up with a diagnosis of autism who maybe don't show these specific behavioral deficits or red flag markers before 12 months of age. So now we're going to look at some video examples. We're going to start with a typical response to name so that you can see a comparison between what a typical response to name looks like and what an atypical response to name looks like. I like to demonstrate response to name because this is something that you can check on anytime you're interacting with a young child who you suspect may have some symptoms of autism. You walk into a room and you call their name and see what their response is like. And I'll show you what the difference between a typical and atypical response would be. So this little boy is Kyle, and he's 12 months of age.
Kyle. Yeah. Hi.
So not only did that child orient towards the caregiver's face when his name was called, we also saw that beautiful change in affect. He did a beautiful smile to the caregiver, directed the eye contact and the gaze towards the caregiver, and even combined that with a gesture reaching towards the caregiver. Now compare that to in this video. You're going to see a child named Evan, who's 19 months old. He is not going to respond to his name.
You want to try to see if you can get him to respond to it?
No. Evan. Evan. Evan.
See maybe if you can get him to respond to you now. You can use touch with his name, like give him a little tickle or something.
Evan. Evan. Evan.
He likes the tickles, but he's just not giving you too much eye contact, but he does smile when you tickle him.
Evan. Evan. Evan.
So you even hear mom change her intonation and her tone as she's calling his name, and still the child's not responding to it, much more fixated on the activities that he's engaged in with the block and other things. So again, this is something that you can practice with children that you're interacting with, even as young as 12 months of age, just calling the child's name from the door. If they don't respond on, say, like the first or second attempt, there may be some concern for social communication development, including autism, or you may have identified a concern for something like hearing. So as I mentioned earlier, once a child reaches 12 months, there are more consistent and reliable behavioral markers that might indicate autism. So in addition to the behaviors that we just reviewed, a child may do other things such as show a lack of a point or lack of following a point to a distal object. So one way that you could ask parents about this one in particular is saying something like, if you're pointing to a toy across the room, say, for example, you say to your child, hey, Evan, look over there. Does Evan tend to look in the direction that you point? Or does Evan try to direct your attention to things that are at a distance? Say like an airplane in the sky or an animal across the road. We're also looking for children to draw attention to objects that are interesting to them. So a child who's not holding up and showing objects or bringing objects to their parent just to draw attention to them is another sign that we see early in development. We also might see a more flat or restricted affect in a younger child who's showing symptoms of autism. So not a lot of variability or emotional expression. They may also not offer comfort to others. That's going to be closer to that into the second year of life. And then any delay in language or loss of language skills or true like regression in skills would be a red flag, as well as limited pretend play. So again, it's always important to know that a child can be on the autism spectrum without exhibiting all of these behaviors, and that in some children, it's more about the difference in quality of the social communication rather than the presence or absence of any particular behavior. So essentially what I'm trying to communicate is that if you have concerns about autism, I would avoid using the presence of any one of these behaviors, such as following a point, to dissuade you from referring for the evaluation. So just because a child does make eye contact or follows your point doesn't mean that they don't have autism. So in this next video, you're going to see the difference in back and forth play between two twins, one of whom has autism and one who does not. I want you to pay attention to the quality of the back and forth play, as well as the child's eye contact, verbal communication, and affect.
Push. Uh-oh. Yeah, it fell off. That's right. Here it is. Uh-oh. Go. Push. Good boy. Ready, set, go. You can push. No, stay up here. Stay up here. Go. Stop. No. Nathan. Go. Look, here it is. Use the train. Stay up here, please. Push. Good boy. Ready, set, push. Go. Push. You can push. Yeah, stay up here. Stay up here. Yeah, it fell off.
So you'll notice that Benjamin, the first twin, he easily engages in back and forth play with the train without much prompting or support from the caregiver. He's also frequently referencing the caregiver with eye contact. Whereas his twin brother, Nathan, picks up the toy, turns away from the caregiver when it's rolled to him. He also demonstrates decreased eye contact and a more limited affect as compared to his twin brother. I think that side by side especially is very helpful. Between 12 and 24 months of age, some behavioral markers that we might see indicative of autism also include some stereotypical behavior. This is the repetitive motor mannerisms. So we might see children do things like flap their hands, posture their fingers in odd or unusual ways. They might twist or flick their fingers, usually in front of their eyes. Some even engage in hand-wringing type behaviors. We also see symptoms of stereotypical or repetitive speech patterns start to emerge between this time. Echolalia is a term used to describe reflective speech. So once the child has heard someone say something, they might repeat what the person just said, either the single word or sentences. It can be immediate echolalia, which is right in the act of hearing that word or sentence or phrase that they repeat it right back. Other times it might be more delayed, where they've heard things on television or things that other people have said and they use it in a different context. The thing that makes it difficult is that children repeat the speech of their caregivers and things that they hear other children say as they're learning and as their language is developing. So one thing that seems to differentiate children with autism in terms of their echolalic speech is how dominant it becomes. So it usually forms a majority of the child's speech. And also, we tend to see more echolalic speech than we do spontaneous speech in many of these young children who have autism. We also are going to see things like non-functional routines. This can be non-functional play routines. So it might be something like needing to complete things in a specific pattern or way, or getting really caught up in small details of how their day goes. Children with autism also have a really difficult time navigating transitions. Now, anyone who interacts with toddlers know that no toddler really likes to transition. But again, the big difference here is not only that we're seeing this accumulation of signs and symptoms and early signs of autism, but also that these difficulties with transitions seem to really impact functioning. So little transitions like needing to stop coloring in order to come to the table and eat, or even moving from coloring to another preferred activity like Lego building, are going to be met with extreme resistance. Other things that we'll see are kind of fixations or obsessions with unusual toys or activities. So some children will get particularly attached to some odd objects. I've had a patient in the more recent past that was really attached to, unfortunately, raw eggs. So just liked to have a container of eggs that they had and could carry around with them, and had such adaptive parents that they were able to clean up those messes every now and then. Other ones are things like bottle caps, paper clips, just anything like kind of unusual. And really, again, it's looking at the functioning. So how much does this obsession or this attachment to the object really dominate that child's life versus in typical development, where we see children have preferential objects or preferential toys, but are able to kind of transition away from them, and they're not interfering with their daily functioning. And then, of course, we have the more repetitive engagement with objects, like lining toys up in a row, playing with small parts of the toy instead of the whole toy. So here's an example of echolalia in a young child with autism.
Hi, Lucas. Hello, Lucas.
Say no, say hi, Georgia.
Hi, Lola.
Give me a hug. Come here. Come here. I gotta tell you something. Hi. Give me a big hug. Oh. How are you?
Hi.
Say, I'm fine.
I'm fine.
Good. Good. Are you playing?
I'm fine.
Cheek, 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 cheek. Ooh, it's cold. Look. Ooh.
In regards to some unusual sensory behaviors that we often see in children between 12 and 24 months, we tend to see hyper or hypo sensitivity to things like smells, sounds, lights, textures, touch. So some children will overreact to these sensory experiences by doing things like covering their ears with their hands, screaming, crying. Others will go to great lengths to avoid engaging with certain textures, or some children will seek out some of these experiences, such as watching things like flashing lights or spinning objects like fans. A lot of times when there are unusual visual sensory experiences, we'll see things like children peering closely at them out the corner of their eye, or looking at things from odd angles. So some children will do things like stand on the top of their heads to look at the underside of tables or other objects. And then another common thing that we see in young toddlers with autism is an under-responsiveness or a high pain tolerance. So we'll often have parents reporting that children will hurt themselves, but they won't know because the child doesn't express any sort of pain experience to them, even when there are some significant injuries like cuts, bruises, even as far as broken bones. So as early interventionists, it's really important that you engage in ongoing developmental surveillance for autism. So during your visits with families, you can ask about things like developmental or behavioral concerns, as well as respond actively to those concerns. So it's important to always ask families about any history of autism in their family, as we know that that leads to increased risk for autism. And then making observations about some of these early signs of autism so that you can get the child connected to a developmental evaluation as early as possible. So I mentioned that there are some things that you can do in your interactions with young children, including things like calling their name. Another one that you can do is probe for joint attention, which is essentially sharing experiences by either having the caregiver point to an object in the room, or you point to an object at a distance in the room to see if the child follows the point. One really great resource for you, if you aren't aware of them yet, is the Autism Navigator. They have wonderful information that you can share with parents and families that you work with on autism surveillance. And the website's included on this slide for your reference. Another project that we have through our Aspire initiatives is our Early Intervention Secondary Screening Project. This is a project that myself and my colleague, Dr. Michelle Villalobos, are heading up, where we are trying to engage our early intervention providers across the state of Utah to train them on secondary screening for autism symptoms. So as part of this project, if you're interested in learning more about screening for autism in the early intervention systems, We utilize a variety of different screening tools, including the Screening Test for Autism in Toddlers, or the STAT, the Rapid Interactive Test for Autism in Toddlers, or the READ-A-T, and then the Tele-ASD PEDS is what that should say. And that one is a telehealth measure that allows you to screen for symptoms of autism. The goal of the secondary screening project is just to give you another tool as early interventionists to help identify some of these early signs and symptoms of autism. But then also to give you a resource for triaging children for a comprehensive developmental evaluation. Part of this project is that we are trying to utilize all the wonderful records and testing results that you as early interventionists do on a day-to-day basis as part of our comprehensive developmental evaluations at UDAC. So children who are screened through the secondary screening process have a different triage through our UDAC waitlist to hopefully connect them to their ultimate diagnostic evaluation somewhat quicker than the traditional referral route. So there is a benefit on that end to you in taking that extra step to do the secondary screening.
Actually, there is one question about those screeners. Are they available in open access, or would their agency need to purchase those?
Yes. So the Tele-ASD, let me start by all of the screeners would require you to undergo some training before you're able to utilize them. The Tele-ASD PEDS is something that is open access at this point, and it utilizes materials in the family's home due to the nature of it being a telehealth assessment for autism. So that is one of the benefits and why some of the early intervention programs that we've trained have chosen to go that route, is that it doesn't require them to purchase extra materials. However, the READ-A-T and the STAT do have individual kits that you would need to purchase in order to do them. Part of our Aspire grant, though, is trying to help facilitate getting these screening tools into early intervention programs. So we do have some funds available to help assist with that. So if you do have interest in this, please reach out to me and we can talk about next steps for it. So far, we've trained 5 different early intervention programs throughout the state, and we've got great referrals coming in.
Okay. Sebastian, look.
Oh, that one played right away. This is an example of how you can try to elicit joint attention when you're in the home. This is off of a measure that we've developed for use in pediatric offices during well child checks, where after a child has shown some risk symptoms of autism, the pediatrician is able to probe for response to name and joint attention. And again, it helps them with some clinical decision making in terms of referring a child for evaluation. So here's how you can kind of elicit joint attention in a quick interaction with a young child.
Sebastian, look. Cool car.
Yeah, simple as that. So it doesn't even have to be a really far distance, just setting something up. I do joint attention probes a lot where there's really nothing that I'm pointing to. I might be pointing to an empty door. It's really all about seeing if the child tracks that point and follows that point to an object, no matter what it is. Another good resource is the CDC's Learn the Signs Act Early initiative. There, of course, were recently revised developmental milestones by the CDC that were done in conjunction with a working group. And so now developmental milestones are designed to reflect what greater than or equal to 75% of children can do rather than just 50%. And then they also added increased milestones at 15 and 30 months, including some surveillance of social and emotional development. this is something that I think also can be helpful as you know a child's developmental level to kind of anchor the family as to what is expected for that child's developmental level as well. And so if you are in a position where you are recognizing some early signs of autism, some things that you can do. First, if the child hasn't had a recent hearing screening, that is always a great first step for the family to pursue. We do want to rule out any unknown or non-suspected hearing loss. That is also part of a comprehensive developmental evaluation, meaning that before a child gets to a psychologist, we want to make sure that they can hear before we give an autism diagnosis. So we're going to order a hearing evaluation. So having that done before you send the referral in is just going to help that family get to that diagnostic evaluation quicker. Sending that referral in for diagnostic evaluations. We at UDOC are happy to see children even as young as 14 months of age. We even see children a little bit sooner sometimes, especially if there's strong family history of autism or a strong suspicion of autism. We can always do some ongoing developmental monitoring and making sure that we're catching this child as young as possible. And then just because there is a specific behavioral intervention for children with autism, ABA therapy that we often recommend, doesn't mean that you have to wait for the child to have that diagnosis of autism to begin intervention. There are many things that you all can do in the early intervention system to help support a child who you suspect has autism, including building some of these social communication deficits and symptoms that I mentioned earlier, like not responding to a point, not pointing themselves, using gestures, increasing eye contact, just remembering that you can incorporate those specific goals into your programming. We are hoping to present in the future on some social communication interventions to you all that you can incorporate into your day-to-day interactions with young children as well. So with that, I'll kind of pause for questions. I have not been monitoring the chat, so I'm sure that there are some.
So there haven't been a lot of questions that have come through. I've tried to interrupt when it has.
Perfect. Okay.
If anybody wants to come off mute or put them in the chat, we will take a few minutes.
I have a question. I have a little one that I see who around 18 months went in for a developmental evaluation and got a diagnosis of autism and is now 24 months. And in the home environment, I don't see any of the signs or indicators for autism.
Yeah.
So I'm wondering what that would look like for a child who does get that early diagnosis that doesn't seem to stick as they develop and grow.
Yeah. You know, first and foremost, there is a phenomenon that we are quite aware of children essentially losing an autism diagnosis. To me, one way that I kind of explain that to families is that is an optimal outcome. That's what we want to see. That means that child's functioning has improved so significantly that we're not seeing that significant impairment. Now, does that mean that the child necessarily doesn't have autism? No. But we also know that in really young children who are diagnosed with autism, it's about an 80% chance that they would have that later diagnosis of autism. So it's possible that patient that you're describing falls into that small category of children who maybe it was a misdiagnosis at that point in time. I think the conversations and kind of where to go from here are the same things that I would suggest regardless of the child's diagnosis, which is making sure that that child's needs and areas of weakness are well supported throughout his development. So maybe he's at a period of time in his development or her development right now where things are looking really well and she's functioning well. But there may be a point later where there's more support that's needed. And so continuing that ongoing monitoring would be especially important. If the family is really questioning the diagnosis, there's no shame in getting a second opinion and having another diagnostic evaluation, especially if that's something that they feel like would help inform decisions that they make going forward.
And then there's also a question in the chat about she was at an evaluation for the older brother, and he had signs of ASD that the parents were aware of, but they wanted to wait to get his diagnosis. So how can we help support parents realize that diagnosing sooner is better?
Yeah, I love this question. I hear this a lot. I get a lot of reports or reflections from parents saying, like, I think he's too young for an autism diagnosis. And so I think one thing to really emphasize is the fact that the reason we emphasize early identification and early access to treatments is because the brain at this point in development is rapidly changing, and we want to capitalize on this period of development before a child's brain becomes more solidified and we're not able to make as stark improvements in functioning. Now, that doesn't mean that having a child who is higher functioning and goes in for an autism evaluation at 4 may not receive that diagnosis at 4 and they do ongoing developmental monitoring. But again, just really emphasizing that having specific targeted intervention for that child can be especially helpful in navigating their future and making sure that they're set up for success.
Okay. Erica, come on mute and go ahead and ask your question.
Yeah. So you'll have to forgive me, my voice, I've lost it again.
Oh, no.
But the gal who was just talking about having a kid that got a diagnosis but isn't showing at my home symptoms. So I've had that happen before where I was working with a child that had a diagnosis, work with them in the home, and you'd have no idea. This child actually was very, when you'd work with them in the home, you're like, wow, these are advanced skills. But what I realized watching this, because you would never think, I ended up doing some visits at different places. So we went to the park, we went to different places in town, we went to different things where it would kind of disrupt the child's routine. And what I actually found is that's when those behaviors came out. Because in home, that was child felt very comfortable, very regulated. They were in their routine. The parents were so good at accommodating. So
Yeah.
home did great with transitions, all these things. As soon as we took him out of those areas, then I saw some of those behaviors.
Yeah,
So
you're absolutely right, Erica, and I'm really glad you made that point. I agree with all of that. A lot of times we see better functioning in the home environment because of all of those extra supports that parents may not be aware of that they're giving, or like you said, the comfort level of the child and the routine that they're used to in that environment. And so when we see those disruptions by taking them out of that environment into the classroom, into the community, we start to see more of that impairment in functioning.
yeah, I saw him at the park. He started doing some hand flopping, and in a year of working with him, and I went, oh my gosh, there it is.
Yeah.
So there are a ton of other questions in the chat, and I would love to get to them all. Just to help everybody understand, we are doing a whole 4-session series on autism for the next few months. So please come back and there may be some response to your questions. The U also has an ECHO network through their pediatric that is all about Autism 101. Ashley, do you know the date of that right off your head?
I do. We are at our last session.
Oh, there.
So
Okay.
we're going to be on a break for a little bit, but all of the recordings from our prior sessions are available on the website. And Janelle, I will get that to you and you can share it with the group, and they're welcome to go back and watch all of our recordings. We do a deep dive into DSM criteria. We do a deep dive into interventions and both developmental and behavioral. We talk about common medical conditions that you see. So it is a great, like a supplemental resource to these echoes that you're doing.
Yeah. And then as Ashley also brought up, the Autism Navigator, they have a free course that's called Autism in Toddlers. That is just a really great course to watch as an early intervention provider.
Yeah.
Also, I'm just going to put in a plug. I am the Act Early ambassador for our state. So if anybody wants some of those free resources to share for developmental monitoring, you're more than welcome to reach out to me and I will send you a packet of stuff. So Ashley, thank you so much for joining us today. That was great information.
No problem. I will see you all again in the future.
Great.
All right, bye.
And then I am going to...
I'll put my email in the chat, and you all are welcome to email me with any questions that we didn't get to today.
Okay. And then I'm going to have Kate, hopefully I pinned you. I'm going to share my screen and you can start talking about your case.
Cool. Well, my name's Katie Emerson. I'm a speech pathologist at DDI Vantage in the Salt Lake area. And I'll be presenting about a little guy that I've been working with since April, so about 5 months now, who does have a diagnosis of autism. Go ahead and go next. So yeah, I'm seeing him in early intervention. He's 23 months old. His primary way of interacting with things in his home and out and about is picking up different objects, whether it's a toy or not, and listening to how they sound when he drops them on the floor. He really likes watching his favorite shows. I think like, was it Letter Party or Word Party or something? And opening and closing doors like cabinets and being outside. It's very self-directed. For communication, he mostly uses hand leading, reaching, and crying. And he's not yet responding to his name or following directions. The family is local to Utah. He's an only child of a widowed mother, and she lives with her mom and dad or his grandparents. Grandma helps with childcare on most days. And he just started a play-based in-home EBA program. And right now they're working on pointing to picture cards of desired items and responding to his name. Yeah. So primary areas for concern are that he's not using any symbolic communication or demonstrating any understanding of spoken requests or instructions. He gets frustrated nearly instantly when he wants something that's not available to him, which makes modeling kind of difficult. He also has only a few safe foods that he'll eat. I hadn't heard a ton about this until I had worked with Mom on this presentation. So this is a new concern to me. It's something we'll probably start working on. And it is very difficult to engage him in play due to his very strong interest in dropping items on the floor and opening and closing doors. Go on next. So these are the goals from his IFSP. Most of these are pre-existing goals from before I started on with him. And he hasn't really made much progress towards any of them. He doesn't yet imitate gestures. He will reach towards a picture that was introduced by his ABA program to request or reach towards an object, but is not yet pointing. And he does kind of enjoy these connection type games or sensory type games where he gets squished by mom or gets tickles from mom, or kind of gets picked up and dropped onto the couch safely. And so we've worked on trying to encourage some sort of indication that he wants more outside of his typical method of yelling and crying. So those barriers are his joint attention. It's very difficult to engage him in joint attention. And he has a very highly focused and unique play style that makes it hard to join in. And mom has a very busy schedule as a nursing student. And then during that wait time or modeling time, he becomes instantly frustrated. So I had trialed an AAC core board with him. He enjoyed looking at pictures on the board, but there was difficulty with kind of the follow through and implementation at home with continued modeling. Modeling ASL is also difficult due to that challenge of obtaining joint attention and the fact that he's still not using those gestures. And I was hoping to have met with his BCBA before this, but we canceled. So hoping to meet with her to develop a plan to potentially implement PECs or talk about more options. So I'd love to get ideas on how to increase his expressive communication, teaching him new play skills outside of his main strong interests in dropping things and opening, closing doors, and then helping him accept new textures of foods outside of his safe foods. Mom told me he likes purees like applesauce, yogurt, PB&J, and does not like foods with more substance like chicken nuggets, bananas, and other things, and also really dislikes interacting with non-food textures like slime and Play-Doh, which she has tried.
Fantastic. Thank you so much for sharing this case. So we're going to do breakout groups. Please make sure that your camera's on. Do a minute for introductions. It really helps build that community practice. We will be trying to bounce Katie through the different breakout groups, but that doesn't always happen. So Shelby and Heather, you guys are both running a group, and you guys will target question number 1, increasing his expressive communication. Pat and my group, along with Jamie, will be doing question number 2, which is teaching him new play skills. And then Kate, you will be answering question number 3 in your group, which is helping him accept new textures of foods outside of his safe foods. So I don't know if anybody wants to take 2 minutes and do any follow-up questions from Katie, or like I said, we'll bounce her in between breakout groups. Okay, Bailey, go ahead and put us in breakout groups.
Okay, just give me 1 sec. We've had some people hop off, so I'm gonna quickly adjust the groups so they're a little bit more even. Okay. Okay, those are open and you should see that invitation. And if you don't, just let me know.
Bailey,
You might just have to join.
which I just paid attention. So we're going to go ahead and have everybody share from one of their groups. So Kate, what about your group? What's one idea? Kate Bennington on mute.
Yeah, sorry. I was pulling out my notes and then I couldn't see to unmute. Oh, we had so many. I don't know.
Just one.
I know. Somebody talked about how he likes to drop things. So using food to drop, like maybe you drop little crumbs into the purees that he likes, or I don't know, just dropping play with food.
Okay, fantastic. Pat, one idea from your group. Just one. Sorry, guys, just one. They'll all be on
All
the
right, all right.
Canvas page.
All right, so dropping again, how to get him from stop doing that, but to incorporate it into the play. So getting a tube, like that you drop into the tube, dropping it into water. So changing the medium, but keep with the dropping.
Perfect. Okay, Heather.
All right. One of the things that we talked about is, again, making certain that he's sleeping well. So again, something that you need to really be paying attention to is his sleep habits.
That's a perfect example. Look at Pat and Heather both kept it to one idea. They are our chit chatters on our hubs. So
Yep.
Shelby.
We talked a lot about the sensory like squishes and tickles and all of that, and adding maybe like a verbal routine or a song or something language related into those activities, since he seems to like those a lot.
Okay, fantastic. And then our group, and I had Maria, but she's not on my screen. She took our notes. So do you have one idea? Mandy.
Yes, so I took your notes, yeah.
I was like, where are you?
So we talked a lot about incorporating a sensory diet before requiring the child to perform or comply.
Hey, perfect. Well, thank you so much. Again, these will all be on our Canvas page. So if you had somebody else take notes, if you will email them to Kate Bennington, she's just dropped her email into the chat, Kate Bennington at DDIvantage.com. She will compile those, and Katie, we will send those out to you. They will also be on our Canvas page that you are able to access at any given time. If you'll take a minute to complete our survey, our next month in October, we will have the Utah Registry on Autism and Developmental Disabilities. Deborah Builder is going to be coming and talking to us about the prevalence and some interesting research that they have just found out about autism. So hopefully you guys can join us then. Thank you so much. Enjoy the rest of your day.